All right, so I'm going to, our next speaker is Dr. Corey Langer, who's devoted many, many years in the evaluation and treatment of patients with lung cancer. He's truly one of the national, international leaders in that field. And he's also been one of the few people actually been interested in cancer and aging for quite a number of years. And I was happy to see at the last, what used to be the GOG meeting, he was there, and now he's part of the NRG, which I think will be a tremendous addition to the cancer and aging group of the NRG. So, Corey, thank you very much for coming to Florida for this.
Thank you, Stu. It's a deep pleasure to be here. Thank Ludovico and Martine as well, two of my inspirations in this field. Lung, unfortunately, is probably, not only is it underrepresented in elderly trials, but we have a relative paucity of clinicians and academics who really have an interest in the elderly, and yet it's so major overriding issue. So again, these are data that are well known to most of you. The U.S. population is shown in blue. Cancer diagnoses rising relatively proportionately faster than the actual population, and you can see the percent change over time. So by 2020, we're going to see about 150% increase in cancer diagnoses compared to maybe a 25 or 30% increase in the population. These are also data that are familiar to most of you. This here database for age distribution. I'm sure there are more updated figures, but lung is really, unfortunately, a cancer of the elderly. More than 2/3 of those diagnosed are at least Medicare eligible, 65 or older, and even higher than prostate, which is about 59% for that same group, a surprising figure for me, and ties with colorectal for the highest proportion of those age 75 or older at the time of diagnosis. If we look ahead to probably the point at which I will be retired, 2030, 45% total invasive cancer incidence, so we've got about 1 in 2 chance, unfortunately. More than 2/3 of cancers will be diagnosed in older adults, and again, lung will help lead that. And in contrast, as you're all well aware, there's major underrepresentation of the elderly in clinical trials, particularly the oldest cohort. So those 75 years of age or older, only 15% of enrollees in lung cancer-specific studies are in that age group, compared to 37% who are diagnosed at that point. 65 to 75 is actually fairly well represented, particularly the 65 to 70 group, but a major drop-off occurs after the age of 70. And this is true really for most of the other major malignancies as well, particularly for breast and colorectal, less so as you might expect for prostate, particularly with all the new agents that are available. These are general principles, but they're particularly pronounced in the elderly lung cancer patients. Physiologic compromise occurs as you age. We have declining hepatic, renal, and marrow function, increased cardiac risk. 80% of those diagnosed with lung cancer are former or current smokers. Actually, a majority are former smokers. But cardiovascular, pulmonary disease are important comorbidities. Immune competence wanes over time. IADL is an issue. Polypharmacy. Some of our patients come to us with medication lists, 12 drugs long, 20 drugs long, some of which they're not taking, other drugs that they are taking that aren't even on the list. So it's imperative that we reconcile those lists and know precisely what they're on, particularly as many of our new agents have major interactions with existing drugs. There's an exaggerated influence of performance status with advancing age, and we've already talked about the high frequency of frailty, but I think particularly in lung cancer patients, those who are older and PS2 tend to fare worse. And then something that we really haven't touched upon, but we must, and that's the impaired social, emotional, and financial resources that exist. The worst prognostic factor I ever see in my clinic is when an elderly patient comes for their new patient visit absolutely alone. And it's the first thing I do, probably even before I begin the H&P, as I call social work. I mean, it's a major issue. An otherwise relatively fit patient who has no social resource is not going to be up to the rigors of an aggressive combination platinum-based regimen, no matter how well they may look and how well they might do on Martine's crash score, at least initially. Lack of consensus is a big issue in lung cancer. What is the standard treatment? Until very recently, there was a total absence of elderly-specific phase 3 trials assessing the role of platinum. And for this presentation, I'm going to confine virtually all my remarks to metastatic or recurrent disease. So consequently, at least historically, there was broad extrapolation from age non-specific data. We would do a huge amount of data mining, as Stu alluded to, taking broader trials and then looking at the elderly cohort and comparing that to the trial overall or to those under the age of 70. And obviously, there are a lot of deficiencies in doing that. Do targeted agents pose a particular challenge or benefit? I'll show you some recent data. Should we segregate the elderly, treat those over 80 differently from those under 80? Dr. Rai alluded to this. If so, how? And then which physiologic considerations do we consider? And I'll talk particularly about renal function and myelosuppression in this regard with some of the commonly used agents in lung cancer. So this is the list. Up until very recently, the prospective phase 3 trials that have been done in non-small cell 70 years of age and older. 4 studies, which I realize is better than some other cancers, but it's still a pretty paltry list considering the lung cancer death rates exceed all others. We have the ELVIS trial, elderly lung vinorelbine Italian study published in the JNCI, relatively small effort, vinorelbine versus best supportive care, that established vinorelbine as a standard of comparison, better survival, better quality of life versus letting nature take its course, essentially. The SIOG trial, even smaller effort comparing a non-platinum combination of vinorelbine, again, improves survival, more toxicity, as you might expect. And then the much larger, much more credible MILES effort, multi-institutional Italian lung elderly study, looking at the constituent single agents versus the combination, and here there was absolutely no difference in survival. And as you'd expect, the combination regimen was more toxic. Finally, a West Japanese trial that compared vinorelbine to docetaxel and actually showed better response rate, progression-free survival, and at least a trend toward improved survival with docetaxel. Note, none of these trials, absolutely none, were conducted in North America. 1 from Japan and 3 from Europe, from one part of Europe, Italy, and from one section of Italy, the Neapolitan region. So virtually all, for those of you who have ancestry from Italy, I salute you. At least they had the insight. Cesare Gradelli and others have really been in the forefront of many of these studies. Here are the actual data. You can see the control group at 1 year, 14% in the ELVIS trial. Vinorelbine alone in the SIOG trial did no better, immediately calling into question perhaps the credibility of that trial, and the much larger, really one of the largest trials ever done in elderly lung cancer, showing no differences between a non-platinum regimen and single agents. This is the Japanese trial we alluded earlier. The prostate talk that perhaps 75 per meter squared is too much. The Japanese have long recognized that. 60 per meter squared is pretty much their standard dose. They compared it to a fairly standard dose of vinorelbine. Again, elderly specific, 70 years of age or older, 4 cycles to progression. 180 patients, toxicities, no major surprises. Global quality of life was similar. Symptom improvement, however, was better with the taxane, higher response rate, significantly so, significantly longer PFS, and about a 5-month difference in overall survival with a 20% difference in 1-year survival. Unfortunately, the trial was underpowered. And so this difference, which objectively looks quite marked, was not statistically significant. And if there's any flaw with many of the Japanese trials, it's the tendency to stop their trials early. The problem with all of this is Those are not standard treatments by and large. Platinum-based combinations are our standard in advanced non-small cell, and virtually all of these data are from retrospective analyses. Most of these are North American. You can see my name here, others who have done these, depending on which cooperative group we were part of. The basic implication of these analyses: no major differences in survival for those who qualify for these clinical trials. Remember, these are generally good performance status patients. A trend for greater toxicity in some studies, particularly myelosuppression. A trend for improved tolerance for carbo compared to cisplatin. No major surprise there. And the major potential limitation, and Cesare Gradelli loves to point this out, these elderly subsets are probably not representative of the general elderly population, just those who actually make it onto these clinical trials, and that in and of itself represents a high degree of selectivity. This is the ECOG 5592 trial. If you recall, this is the trial that led to paclitaxel's approval in advanced non-small cell, comparing it to our erstwhile standard of cisplatin and etoposide. These folks had more cardiovascular and respiratory comorbidities, more toxicity, particularly leukopenia, and more neuropsych toxicity, whatever the heck that is. They didn't have separate categories for fatigue, for lassitude, and I suspect a lot of those other side effects were grouped under neuropsych. However, there was no difference in treatment outcome index or delta change over time. No major differences in response rate, time to progression, median 1 or 2 year survival. So if you were fit enough to get on the trial, age made no difference. And really performance status, in my view, trumped age, even as many clinicians and academics started doing trials grouping both PS2 with the elderly, which I think is a major error. Fortunately, in the last few years, there have been elderly-specific trials looking at the role of platinum. This is a JCOG trial comparing weekly docetaxel, so 25 per meter squared, 3 weeks out of 4, with a weekly platinum docetaxel combination. Note they attenuated the docetaxel dose a little bit in the combination arm. Again, the major entry criteria: advanced disease, 70 years of age or older, and PS0 or 1. This is based on phase 2 data by Ohe and colleagues, 33 patients who received this combo. Response rate fairly respectable, over 50%, median survival of 16 months, 1 and 2 year survival rates of 64% and 26%. We don't see these numbers typically in North America. The Japanese always do better, doesn't matter what. Lung cancer, whether they have mutations or not, whether they get standard chemo combinations, they do on average 2 to 4 months better when it comes to median survival. The study was stopped early, prematurely, after the DSMC determined that the 70 to 75 age cohort had a major benefit for the combination over docetaxel. You look at the overall group here, about a 6-month difference, more than 20% improvement in 1 year survival, more toxicity as you'd expect, but certainly acceptable. The problem here is these differences were not statistically significant. So a positive leaning study that was closed early. They also stopped the trial early because those over 75 seemed to have more deleterious effect, and it really they felt that they had to segregate out the two age groups. Probably the most important trial and the most informative, and it made it to the ASCO plenary session about 5 years ago, published in Lancet 4 years ago, is a Qua trial. The French really are powerhouses when it comes to clinical trials, and this was a direct comparison of a platinum combination, in this case carbo with weekly paclitaxel, versus standard single agents, either vinorelbine or gemcitabine. So the study schema is shown here. Note all of these folks at the time of progression went on to an improved second-line regimen, in this case erlotinib. You had to be over 70, under 90. They allowed PS2, second largest study ever done, over 450 patients. And the enrollees were stratified by center, performance status, age, and stage at enrollment. So here are the study schemas. They certainly didn't stint on the vinorelbine dose at 30 per meter squared, days 1 and 8. The Europeans tend to use higher gemcitabine doses than we use here in the U.S. Carbo is given monthly, AUC is 6, and paclitaxel weekly, again, trying to reduce the toxicity, 90 per meter squared, days 1, 8, and 15. The eligibility are shown here. Again, PS2 up to the age of 90. No prior treatment with except for surgery or palliative radiation, so they had to be chemo naive. Adequate hematologic, renal, and hepatic function, so right off the bat, you're culling out many of the potential enrollees. I never write in my chart notes someone has a life expectancy of at least 12 weeks. If I get rid of anything on eligibility, it's that if they've got a decent performance status by inference, they have that life expectancy. So then you go back and then you edit the charts and put that in because you don't have the source documentation. Drives me crazy. Exclusions, symptomatic brain mets. So again, we've seen the light. We allow prior treated brain mets. Another exclusion that we need to get rid of, at least in the metastatic setting, the stupid 5-year rule within the last 5 years, chemotherapy at any time. My elderly lung cancer patients with liver, bone, and brain mets, they should live long enough to die of their micrometastatic breast cancer that was diagnosed 2 years ago. But again, those sorts of folks are excluded, and we've recently gone back at ECOG and looked at the percentage of patients who fall out because of that. 20% of otherwise eligible patients. So silly exclusions, but they're all boilerplated in. So the primary endpoint here is survival, as it should be. Standard secondary endpoints of response rate, response duration, quality of life, which I think is very important, and survival after first line. They were looking for over 520 patients, looking for a 10% absolute improvement in 1-year survival from 30 to 40%, and about a 2-month improvement in median survival. At the first planned interim analysis, it did not meet the stopping rules. However, at the second analysis, it did. There was a survival benefit with a p-value of less than 0.001, and so the monitoring committee recommended an early closure of the study, about 70 patients shy of their original targeted accrual. So here are the numbers. Median follow-up, fairly mature, at about 22 months. Again, survival and PFS analyses on an intent-to-treat basis, as it should be. Here are the demographics. Vast majority were male. This is a French study, over 70%. Median age, 77. Over a quarter were PS2. The vast majority were stage 4. And a bare majority had adenocarcinoma. About 20%, now I would argue this is somewhat high for France, but 20% were never smokers. That is a fairly standard percentage here in the U.S. Well, again, the fitter, what kind of patients are going to make it to this trial? The never smokers who are probably a little bit fitter. They also looked at other factors. They had a baseline mini mental status exam, 16% had actually somewhat lower scores. Baseline ADL assessment, again, 20% did not score well. Comorbidity using the Charlson Index. Most of these folks had relatively few comorbidities, 75% with a score of 2 or less, nearly 50% with more than 5% baseline weight loss, which we know is a prognostic factor. If we look at toxicity, no major surprise, the combination with carbo is going to be more toxic, and it was. More neutropenia, more febrile neutropenia, more thrombocytopenia. When we look at non-hematologic toxicity, again, relatively more neuropathy, although with the weekly schedule is only 3% grade 3 or higher, a bit more anorexia and diarrhea in the combination arm compared to the single agent arms. A threefold improvement in response rate, 11% versus nearly 30%, favoring the combination. We see a doubling in progression-free survival from 3 months to 6 months. Lots of zeros in that p-value. They don't even write it out. They just 10 to the minus 6. And in survival, this is one of the more prominent curves for survival in solid tumors, particularly in lung cancer, and really one of the only ones for the elderly in lung cancer. 4-month difference, you see a 20% difference in 1-year survival. These numbers are credible. This is what we had seen previously with the Vinorelbine in the pretty much in the Elvis trial. Separation occurs fairly early on at about 3 to 4 months. Again, lots of zeros in the p-value. So it's not only the regimen, performance status, PS2, prior or former smokers, squamous cell histology, poor ADL, more weight loss are all prognostic factors in multivariate analysis. What about the older group? They did break this down in the forest plots, and those over 80 actually, if anything, had an even greater benefit. The hazard ratio for the 114 patients in that cohort, 0.56 with a p-value of 0.0067, pretty much matching the 70 to 80 group. So this was the first study entirely devoted to elderly patients showing the superiority of a platinum doublet, in this case carbo, over single-agent therapy. And remember, up until relatively recently, in fact, some of the guidelines still include this, the recommendations of ASCO when this study was initiated was single agent, period, based on the Italian trials. But here, carbo in combination with weekly taxane resulted in major improvements in response rate, PFS, overall survival, reasonable, I would argue, acceptable toxicity profile. And they argued this is the new paradigm. Now, does it have to be weekly paclitaxel? We can debate this. It could certainly be gemcitabine, pemetrexed. It's just that those agents haven't been separately studied prospectively in this context. Well, what about other agents? So this is NABPAC. I'm going to mention its proprietary name once. It's Abraxane. And I'll go back to the generic. Using a very similar schedule, 100 per meter squared, days 1, 8, and 15 without interruption. Carbo dose was fixed in both arms. Compared to a Q3 week schedule of PAC carbo. Now, this was a much larger all-comers trial, over 1,000 patients looking for similar response rate between the two taxanes. You see a benefit, comparable response rates overall, and actually a significant benefit in the squamous cohort. Did not translate into an overall PFS or overall survival benefit, except possibly in the elderly. So again, 70 years of age and older, and now this was one of the stratifications for the trial, but it wasn't per se a planned analysis. But 150 patients, you see a 9.5-month survival difference favoring the NABPAC weekly arm with a hazard ratio of 0.583. And I've had an opportunity to delve further into the data, so here are the relative survival curves. Those under 70, no major difference. Those over 70, significant difference, and hazard ratio of 0.58 with a p-value 0.009. Word of caution, the PFS curves do not show the same survival difference. It immediately calls into question whether some other factors, perhaps second-line treatment, might have influenced this. The standard, yes, Martine.
The major difference between nab-paclitaxel and paclitaxel is that you avoid some steroids in the story.
You avoid steroids, you lower the HSR rate probably, you give it faster. I think the other major difference, and we have to own up to this, is very different schedules of taxane. Remember, the control arm was Q3 weeks with all the attendant toxicity, as I show here, and the NABPAC was given weekly. So there are two variables in this study, and I think that needs to be highlighted. And the increased toxicity in its own right may lead to more treatment withdrawals or other issues that come up in the conduct of the trial. So the over 70 group, you see relatively greater incidence of sensory neuropathy and neutropenia in the conventional solvent-based PAC arm compared to NABPAC. There's an advantage in both groups, but the elderly seem to have a relatively greater relative benefit with respect to those two major toxicities. If we look at quality of life, the total scores favor NABPAC, peripheral neuropathy, hearing, pain, not so much in edema. And again, this is shown in some of the subscales. This is one of the areas where I think we have to be careful. The over 70 group who got NABPAC were a bit more likely to go on to second-line treatment. And maybe they were just in better shape because they weren't beaten up by standard solvent-based PAC. But when you see a lack of PFS benefit but a survival benefit, you have to really drill down further into the data. So what's the obvious conclusion? Well, not that NABPAC's better, but maybe the schedule may be the issue. So this is what I would like to do. It has not yet happened, but essentially comparing conventional solvent-based PAC weekly versus NABPAC weekly in the same sort of population that trial conducted. So taking the QA regimen and comparing it to the Szynski regimen with that same 1-week break. But we're not quite there. This is an ongoing trial through Celgene, the Abound 70+, that is comparing with really respect to safety and tolerability as well as other major secondary endpoints, this weekly uninterrupted schedule versus the QA schedule. So 3 weeks on, 1 week off, as used in the IFCT versus the weekly schedule used in the Szynski Celgene trial. It's accruing slowly but surely. It's got about 50 patients so far. And if these data hold up with fewer dose interruptions and similar PFS and OS, then I hope to get my wish and actually compare the two taxanes. I'm going to segue to targeted therapy. There's potential increased use, of course, in the elderly, given the favorable toxicity profile. Many of these drugs, we have very limited prospective data to date. I will show you what I can find. Subset analyses, again, I've extended to the elderly using extended access trials, showing fairly comparable outcomes. We do have some prospective randomized phase 2 data, prospective phase 2 elderly-specific trial with erlotinib that suggested a benefit. Back in the era when vinorelbine was the standard, really very little difference between gefitinib and vinorelbine with respect to survival, but improved quality of life. And the retrospective analyses of EGFR mutant data in the elderly, I think, look promising, and this is really data I've been able to uncover over the last few weeks. And finally, we'll talk a little bit about bevacizumab. So this extremely busy slide summarizes BR21. If you remember, this is the trial that led to erlotinib's approval in North America. It was largely Canada, European collaboration. There were all of 3 Americans on this trial. Compared erlotinib to placebo in the second and third line setting in chemo-ineligible patients. So third line if they had gotten platinum-based chemo up front, then docetaxel. Second line if they could not get additional chemo. And overall, even in unselected patients, it showed a survival benefit. Here are the basic data. This is for the younger cohort. You see very similar numbers for the elderly, although it's not significant. It's probably underpowered. Certainly a PFS advantage. Response rates were similar between the elderly and the younger cohort. The elderly patients had significantly more overall and severe grade 3 and 4 toxicity. The relative percentages are shown there. They were more likely to discontinue treatment as a result of treatment-related toxicities. They had relatively lower dose intensity, yet despite all of this, they still had an apparent benefit with similar survival and quality of life compared to the younger cohort. This is the only elderly-specific trial testing TKI from the MGH group, published in JCO about 7.5 years ago. Looking at erlotinib, in those over 70, they allowed PS2, fairly standard demographics, the vast majority with adenocarcinoma. And here, almost all were never or former smokers. Expected toxicity, rash and diarrhea are ubiquitous with these agents, usually grade 1 or 2, but still quite annoying. 9 patients had to stop treatment because of toxicity. 4 out of the 80 patients accrued had to stop for interstitial lung disease, something we don't think about that often. One of this proved fatal. The overall response rate was pretty low. Remember, this is unselected patients at 10%. Disease control wasn't bad at 50%. And the responders had a higher concentration of never smokers and women, as we'd expect in this population. These numbers are very similar to what we'd see with standard chemo in the same cohort. And when they went back and looked at EGFR mutation, it was found in 9 of 43 tested and clearly correlated with response, time to progression, overall survival. This is the only head-to-head comparison of a TKI versus chemo. Just under 200 patients accrued by Lucio Crino, published about 6.5 years ago in JCO. Again, comparing vinorelbine, standard single agent, versus gefitinib with PFS, the major endpoint. Again, an elderly-specific trial, had to be 70 or older, PS 0 to 2. No major differences. This 2-month difference in overall survival was not significant. The curves bulge a little bit at that point, but then come back together. You can see very similar disease control rates, PFS. Overall response rates are quite poor. Toxicity, as you'd expect, more neutropenia in the vinorelbine arm, a lot more rash and diarrhea in the gefitinib arm. So here are the relative hazard ratios. And ironically, and at this time we thought FISH would be a discriminant of benefit for TKIs, the FISH-positive group actually did better. The FISH-positive for EGFR did better with vinorelbine. So here are the outcomes, and PFS is shown on the left, overall survival on the right with very little difference. So similar efficacy, gefitinib better tolerated with better quality of life, and a potentially paradoxical benefit for vinorelbine, the FISH-positive group. Well, by and large, we don't give TKIs up front in unselected patients. In fact, you probably shouldn't. But in those who have mutations, EGFR mutations, about 10 to 15% of our non-small cell population. And if you're female, never smoker, adenocarcinoma, East Asian ethnicity, it's 65%. A TKI up front, and doesn't matter which one, is the standard. Whether we look at studies evaluating gefitinib, erlotinib, or afatinib compared to standard chemotherapy, we see a consistent major improvement in response rate, a consistent major improvement in progression-free survival, but no improvement in overall survival, at least until very recently. And that stands to reason. These folks, when they have disease progression on standard chemo, they're going to cross over to the TKI at the time of that progression. So by and large, at least in the broader populations enrolled in these trials, although we're looking a lot better than we did with chemotherapy alone, typically 12 months, 13 months at most, there's no difference. So it matters. You need to get the TKI, whether you get it first or second line, you could argue it makes little difference. This is the Roselle trial. It's the first trial to look at erlotinib, and I apologize, it got the trade name, but this is straight from the Lancet Oncology, so they actually used the trade name in the publication, and they can't alter it. So the TKI was better than chemo with respect to PFS, and you can see a sharp divergence in these curves, p-value of 0.001 with a hazard ratio of 0.34. And then the recent afatinib trials, LUX-Lung-3 compared to afatinib, to what many of us would now use standardly in advanced non-squamous, pemetrexed and platinum. In this case, it was cisplatin. So these were all mutant positive patients. They also included less common mutations beyond exons 19 and 21. This is the overall group at 12 months, more than doubling in progression-free survival, about a 5-month difference overall. If you look at the common mutations, 19 and 21, the median PFS in the afatinib group goes up to 13.6 months. Well, here we do have some elderly-specific data. And if you look at those over 65, and again, I guess we have to distinguish elderly from Medicare eligible. I don't know what to call 65 to 70. As I get closer, it doesn't seem elderly either. So the 134 patients who are over 65 still have a hazard ratio of 0.64, clearly favoring the TKI. It does cross unity. It's probably underpowered for the analysis, but the trends are very consistent. What many of you are probably not aware of is that afatinib is the only one of the 3 TKIs that's actually shown a survival advantage versus standard upfront chemo, specifically in deletion 19 mutations. So here are the data. LUX-Lung-3 was the global trial, the one that led to approval here in the U.S. for afatinib in EGFR mutated patients. In that group, hazard ratio is 0.54, favoring afatinib up front versus PEM platinum. LUX-Lung-6 was a Chinese trial comparing afatinib to GEM cisplatin. You see the same relative advantage, hazard ratio of 0.64. And here are the curves for those 2 trials. And these are not trivial improvements. This is about a 12-month difference in median survival in the LUX-Lung-3 and about 13-month difference in LUX-Lung-6, with that separation occurring very early on. Now, does this mean afatinib better than erlotinib or gefitinib? We don't know. We have not seen data yet comparing the 2. Those studies exist. They have not yet been reported. So maybe, maybe not, but it is the only TKI where we have observed the survival difference, at least so far. at least, and it also strongly suggests that even though 19 and 21 are both EGFR mutations, they're really somewhat different populations, that 19 by and large seems to be a bit more sensitive. What about age-specific? So this is hot off the press. This publication came out in Lancet Oncology just a few weeks ago, and you can see that this benefit, if anything, is even more pronounced in those who are Medicare eligible. Hazard ratio 0.73 in the LUX-Lung 3, and in LUX-Lung 6, 0.60. Again, the numbers overlap unity on these forest plots because the numbers are relatively small, but in aggregate, there clearly is an advantage. Let's segue now to the other targeted agent we commonly use in lung cancer, bevacizumab. Most of you are familiar with ECOG 4599, the phase 3 trial that led to the approval of Bev in advanced non-squamous, non-small cell. Remember, this drug in combination with chemo led to an untoward incidence of pulmonary hemorrhages in the squamous cohort. So this was the ECOG trial. With usual stratifications comparing chemo alone to chemo plus Bev. You see a 2-month improvement in median survival, a consistent 7-8% improvement in 1 and 2 year survival. So it's not one of those banana-shaped survival curves where they join at 1.5, 2 years. The benefit persists over time. More toxicity, even culling out squamous patients. You see a 4-fold increase in hemorrhage. A significant increase in neutropenic fever and neutropenia overall, and 15 treatment-related deaths in the Bev arm compared to 2 in the control arm. Yet, despite this, and including these numbers, you still see the survival benefit. Over time, we've become a bit more relaxed about which patients we'll treat with bevacizumab. Squamous is still an exclusion. Antecedent hemoptysis is still an exclusion. I have my doubts about giving this to poor PS patients, but treated brain mets are no longer an exclusion. Clearly, the safety issue no longer exists. And the AVAIL trial and others have shown that you can give this drug safely, even in those getting ongoing anticoagulation. So you eliminate those two groups. Roughly 50% of patients with advanced non-small cell, at least non-squamous, are probably eligible for bevacizumab. So what about the elderly? Well, this was Suresh Ramalingam is the chair of the ECOG Thoracic Committee. Secondary analysis, we see about 25% of those enrolled on 4599 were in fact 70 years of age or older. Borderline significant improvement in PFS, but in this subgroup, no overt survival benefit and more grade 3 and 4 toxicity. More neutropenic fever, more bleeding, more muscle weakness, more neuropathy, and borderline significant increase in treatment-related deaths. And based on those data, that many of my colleagues have been very gun-shy about giving Bev in anyone over the age of 70. Well, here are the PFS curves, so still in near benefit, not quite, but a trend. Overall survival, not significant, although you see the curves beginning to diverge beyond the median. It may be a bit more nuanced. Heather Wakely went back and looked at both gender and age, and really the benefits are observed in men of just about any age and women at least under the age of 60. If they're over 60, the control group seems to have done much better than one might expect. So here, the control groups are shown in the dashed lines, the Bev arm shown in solid, reddish pink are the women, blue are the men. I apologize for the color stereotypes, but you can see women over 60, no difference for basically every other cohort, statistically significant benefit. Well, that's sort of unsatisfying. It's small numbers, it's post-hoc analysis. So what we went ahead and did a richer post-hoc analysis. For those of you not familiar with it, Point Break was a trial that compared the experimental arm of 4599, PAC-carbo-bev, to PEM-carbo-bev. The only difference was 4 cycles of the combination agents in Point Break, and we allowed brain mets in the Point Break trial, which we had not allowed in 4599. Other than that, eligibility was absolutely identical. These were all advanced non-small cell patients, non-squamous histology. So to further define the relationship with respect to age, we pooled the PAC-carbo-bev patients from Point Break with the PAC-carbo-bev patients from ECOG 4599 and compared them to the PAC-carbo-only patients from 45-99. So again, the distinctions, the doses of PAC and carbo and bev were identical across all these trials. We looked at many different age stratifications: under 65, 65 to 75, 70 to 75, under 75, and 75 years in age and older, and realized in Point Break that cutoff of 70 was actually a pre-specified analysis, and looked at both PFS and overall survival. So if you evaluate the demographics, they're well balanced, whether you look at either age group, those over 75 and those under 75, with respect to stage, histology, ethnic background, or gender, as well as performance status. And here are the basic data. This on the right is 45-99 alone. On the left is the combination. And I'd argue 75 is the new 70. Under 75, 65 to 75, under 65, you see a survival benefit. Above 75, that benefit is lost. And that's mirrored in the PFS forest plots as well, whether you look at the joint analysis or 45-99 alone. Here are the curves for the under 75 group, again favoring BEV. No such benefit seen in those over 75. And here are the median survival. So you see about a 3-month difference, 13.4 months versus 10.2 in those under 75. And the reverse is actually seen for those 75 years of age or older. A lot more toxicity, as you'd expect, but it doesn't matter for either age group, although it's a bit more pronounced in those 75 years of age or older. For those over 75, a 4-fold increase in grade 5 AEs, 2% versus 8%. Now, granted, these are post hoc retrospective analyses, but when it comes to safety, it certainly influenced my practice, and I think twice about giving BEV to anyone over the age of 75, although I'm certainly relaxed my rules between 70 and 75. So again, no significant PFS or overall survival benefit above 75, a preserved benefit for those under 75. And I would argue that it is not contraindicated in the elderly, and we also have some recent SEER data that I haven't shown you that could potentially extend even beyond this age group. I want to finish up with the very old, I don't know what you call this group, the oldest cohort, but at least those over 80. The number of lung cancer patients 85 years of age or older will quadruple by 2050. Think about that. Where my mother lives in an independent living in Monroe Village in central New Jersey, the median age for the 300 people there is 88, which is exactly her age. They're 65 to 104. I have never seen so many nonagenarians in my life, most of whom are still walking and talking. This is reality. And despite Ezekiel Emanuel's absolutely firebrand editorial in the New England, it might have been the New England Journal too, but New York Times, saying that our meaningful life has ended at 75. You go to Monroe Village, they'll be after you with pitchforks. So I really, and he works in the same institution I work in, which aggrieves me terribly. So unfortunately, in this group, prospective data are extraordinarily limited. I went back and looked at 1594. Now remember, this is the 4-arm study that looked at various platinum-based combinations, showed absolutely no difference between any of these. All of 9 patients were over the age of 80. That's out of 1,200 accrued. That is less than 1%. And they did badly. None of them were able to get all 6 cycles. There were no responses. The PFS and median survival is about half that observed in the 70 to 80 age group, which pretty much mirrored the rest of the population. And you can see, by and large, these folks, again, this was cisplatin-based regimens, could not get through treatment. Paul Hesketh and Rogerio Lillenbaum have looked at the influence of performance status, and at least amongst those over the age of 80, I think it affects outcome even greater than those under the age of 80. You see a marked drop-off. But go back to the Quad trial, the French trial, which is a little bit more contemporaneous, which did not use cisplatin, used carbo, which used weekly taxane. You're still seeing a survival benefit for those over 80. So I don't think you can apply this as a blanket rule. This is the largest cohort, by the way, 114 patients over the age of 80. Finish up with protoplasmic issues. Comorbidities, of course, we already know can have a deleterious influence on survival. There are normal physiologic changes with aging that will often restrict our therapeutic options. Renal function is a big example. Carbo is likely preferable to cisplatin in a significant percentage of our patients. They can get carbo, they can't get cisplatin. Pemetrexed, remember, which is commonly used in advanced non-small cell, has not been formally tested in creatinine clearances under 45. You have an 80-year-old woman who weighs 100 pounds with a creat of 1.3. Her creatinine clearance is below 45. So to just automatically assume PEM is safe in an older person who has ostensibly normal renal function is a fallacy. Myelosuppression gets worse with aging. Fortunately, we have only one really myelosuppressive drug, and that's docetaxel in lung cancer. I routinely give it with growth factor support. Doesn't matter what age they are. And for the older group, I tend to give 60 per meter squared. So again, this is 5592. You can see those over 70 had more comorbidities, significantly more respiratory comorbidities, more non-analgesic drug use, more additional diagnoses beyond the heart and lung. If we look at the SIOG trial in the elderly, which evaluated sequential vinorelbine to docetaxel, those without comorbidity clearly did better compared to one or two or more. And if we look at the Italian trials, those with higher Charlson scores were more likely to discontinue treatment early and also had inferior median survival. So there's a major interplay between age, performance status, and comorbidity index, even before we get to frailty indexes or CGAs, which unfortunately absolutely none of these trials have looked at. Again, the Cockcroft-Gault formula, which we use to calculate carbo dosing, has age built into the formula, and so makes carbo, fortunately, a safer drug. We have Hilary Calvert to thank for the actual approval of this drug. It would have been quite unsafe if we just did milligrams per meter squared. Are there other preferred agents? Well, I already showed you the docetaxel data. I think there's a suggestion that taxanes are better than vinorelbine. We've certainly seen that in combination. We see that with single agents, at least with respect to response rate and PFS, probably with respect to survival. And then the TAX-326 trial is a relatively old trial comparing vinorelbine cisplatin to docetaxel cisplatin. And lo and behold, in those over 65, you see a 3-month difference in median survival favoring the docetaxel group. And again, this Medicare population. Of course, Medicare doesn't apply to Europe, where this trial was done. So here are my conclusions. Median age at diagnosis in lung cancer is 70, but the elderly are underrepresented in clinical trials. We're trying to do better. We have done better, but we're still way below that threshold. The elderly, as you're all well aware, are more likely to be frail and are vulnerable compared to younger patients. Functional reserve is compromised even in those who seem fit. Whether some modified version of the CGA can be implemented seamlessly in clinical trials, I think that's going to be a major debate. We have actually tried to do elderly-specific trials in both RTOG, now Energy, and ECOG, and were shot down by the NCI. It was ageism. How can you do an age-specific trial? Prove them to the regular trial. We were pointing out the fact that we weren't doing well, but they said we couldn't do it. The fit elderly fare as well or nearly as well as fit younger patients, although toxicities are worse. Dr. Kish, Julie Kish, is going to be presenting important data at ASCO during the head and neck plenary, focusing on combined modality. And I don't want to spill any beans, but the conclusions for head and neck may be very different from lung. Level 1 evidence-based data show clear benefit for non-platinum monotherapy versus best supportive care. No consistent superiority for non-platinum doublets with comorbidity predicting outcome. We have tons of retrospective analyses. We don't need any more. Platinum-based combos showing similar outcome for the elderly and younger individuals, whether we look at response rate, time to progression, quality of life, overall survival. And now, finally, at least one elderly-specific trial proving therapeutic superiority for platinum-based combo. There is another trial from Japan that actually tried to do it and did not show a benefit. Notice I didn't show you that. I have a bias. I think what happens in Japan sometimes needs to stay in Japan because it doesn't necessarily translate to the rest of the world, even to other parts of East Asia. Decisions regarding treatment hinge on multiple factors: toxicity profile, performance status, pharmacokinetics, comorbidities, organ function, and we can't discount social support. An otherwise fit person who's unaccompanied probably has no business getting aggressive platinum-based chemo with Bev. And those over 80 may really be a different group, although the quad data would call this into question, and ideally you have to individualize, not ignore the data. So this actually is not my slide. It comes from Hak Choi. I had done an elderly sub-analysis. I presented during a poster discussion at ASCO, and he put this up. And he's right. You're never too old to go on a clinical trial. And if you're in the Delaware Valley on any Wednesday at 7:30 a.m., you can come to our tumor board, my former tumor board at Fox Chase. At 5 o'clock, you can come to the Penn tumor board so you can stay in town. This is me. My mouth is always open. I'm either talking or shoving food in it. The surgeon comes pre-equipped with blades on his back. The radiation oncologist, sort of quiet, contemplative, but he can gore you with his spikes here. The interventional pulmonologist towers over all of us. And finally, I'm not sure what the pterodactyl represents, whether it's the insurance industry or the hospital administrators or the NCI, but you're all welcome to our brainstem storming sessions. Thank you. Do we have enough time, or do you want to? Yeah. So this is a 74-year-old 50-pack-year smoker, avid golfer with a history of COPD, hasn't kept him off the links, presents with increasing shortness of breath and cough, big left pleural effusion, 1,000 cc's fluid, color of Zinfandel. Cytology is positive for adenocarcinoma, TTF1 positive. Subsequent CAT scan confirms the effusion, big 4-centimeter left parahilar mass, bulky hilar and mediastinal adenopathy, actually should be lung nodules in the contralateral lung. Brain MRI is negative. Remaining workup is negative for metastases. So a T2A, N3 because of contralateral nodes, M1A, all the disease is confined to the chest. It's not out of the chest. We have a very complicated staging system for lung cancer. And one of my mentors, Bob Comas, always said, the more complicated the staging system, the fewer people you're curing. And he's absolutely right. So further workup actually reveals KRAS mutation. I will send molecular testing on all adenocarcinoma patients regardless of smoking history and all never or remote former smokers regardless of histology. A heavy smoker, squamous, African-American male, the chance of having any sort of mutation probably under 0.5%. You could, frankly, I think we should send it on everybody, but if you're playing percentages and that person's symptomatic, waiting around for finding a marker, you're really better off giving chemo. So there are 3 agents in the frontline setting based on retrospective analyses that can further enhance survival. We shouldn't have bolded this. This is the only one. Remember, ramucirumab has been approved in the second-line setting with docetaxel versus docetaxel alone. I don't have the elderly-specific data from that trial. I hope to get it. Erlotinib and crizotinib, they are not indicated. This patient, EGFR wild type, ALK wild type. No translocation, no role for crizotinib, period. And erlotinib is really in the second or third line setting, and even then you could make an argument. So Bev has a role. Patients under 75, no brain mets, no antecedent hemoptysis, fairly fit, reasonable performance status. I would have given this person probably Bev carbo and either PEM or paclitaxel, probably PEM, assuming the creat was good. So the patient actually got carbo with paclitaxel weekly. After 3 cycles, he's doing great. The effusion's gone, the left hilar mass and associated adenopathy reduced by 60%. The contralateral pulmonary nodules have disappeared. The patient's developed numbness and tingling in his hands and toes, and it's interfering with his golf game. He also notes digital pain at night. So what is the next step? I'm not sure. Why don't we just survey everybody? I mean, this is a common situation that extends beyond lung cancer. So what would folks do besides sit there and stroke our chins? Well,
90 per meter squared is pretty tough.
90 per meter? So you would lower the dose?
I might just...
Or delete the taxane?
Because he's getting such a great response. I hate to totally
So here are the choices. Stop treatment, add gabapentin, and observe closely. It's gotten 3 cycles with good response. Stop treatment, add gabapentin, and enroll in hospice. I don't think any of us would do that, although some of my colleagues would, including a prominent brother of the mayor of Chicago. Continue treatment, add gabapentin, and reduce the paclitaxel dose to 60 per meter squared. Continue treatment, add gabapentin. Substitute NAB-PAC? No. Okay. Whoa. Okay. No. Continue treatment, add GAP, and substitute GEM for Taxol. So what would? So you'd lower the dose. So the consensus is number 3 here. Yeah, that would have been my choice too. Why not NAB-PAC? If it?
Because Abraxane, in my opinion, in older people creates much more neuropathy than paclitaxel. And that's my experience. It's not reported anywhere, but and I won't tell it in front of my friends of surgery, but it's not a drug that I love particularly.
Yeah, the problem in the study was Taxol every 3 weeks versus not Taxol weekly.
Mm-hmm.
We know Taxol weekly creates more neuropathy than. Right.
So you would do what? You'd continue the carbo, and what would you do with the taxane?
No, I would reduce the dose of
Dose.
I would reduce the dose of the Taxol.
And probably maybe go 4 cycles instead of 6. But I think the person's benefiting, is doing well. Remember, he's got stage 4 incurable disease. He's not going to survive this.
Again, the number of cycles. So some people think that you have fixed in the stone. Personally, I think that you don't think that way. I think that as long as a person benefits, it's worthwhile to continue.
Something.
And
Yeah.
I mean, one thing I wanted to say about let me say that Avastin is a drug that I deeply dislike and despise.
Okay. With that preface.
Having said that, however, I'm sure that I'm not convinced by those data that you showed. When you look at the number, the people less than 75 were 1,178. Those over 75 were a little more than 100.
Right.
Really,
It's small
it's
numbers.
the power of
Granted.
that difference. I think we have to be a little careful. It's like adjuvant chemotherapy in breast cancer in the meta-analysis.
It's a post hoc analysis. It's retrospective. It's hypothesis generating. You're right in the sense that perhaps we shouldn't draw broad conclusions from it, but it's the only analysis I have for the 75 and older.
With lung cancer of Herceptin is like deprive a patient with melanoma of dacarbazine. But so I would not be particularly bad, but I think that we need to be careful when we make analysis like that. The other thing you say that afatinib was the only one that showed the improvement in survival. But that study that published in Lancet Oncology with the Tersiva, that showed an improvement in survival too, or am I wrong?
No, they all showed a response. So erlotinib versus chemo in mutation-positive patients consistently shows a response and PFS benefit, but no survival benefit either. Well, let me preface that by saying either they didn't show it or what they showed wasn't significant. So maybe there was. I keep going to the companies and saying, if Fatinib's shown a survival benefit, where's your data? As best I can determine, the data do not exist. But what we do not yet have are the head-to-head data, and there is an East Asian study that's comparing them. Yeah.
What do we know about use of nivolumab in refractory squamous?
So I completely avoided that, partly because I don't know the elderly specific data. So to get everybody up to speed, Nivo, of course, has been approved, second-line squamous, superior to docetaxel in that population, and not just a little bit. The package insert has the curves, about a 3.5-month survival benefit. The data have yet to be presented at a meeting, so I have no clue what percentage of the folks on that trial were over 65 or over 70. I think once I have that, it'll be part of this talk. I suspect it'll be the same. As pointed out in the prior talks on melanoma by Dr. Weber, these drugs are relatively safe. They're relatively easy to give. Not necessarily the CTLA-4 inhibitors, but the PD-1 and PD-L1 inhibitors. Several of my patients have said, this is the least toxic thing they ever received. And so I eagerly await that. Now, again, squamous, more likely to be a bit older, probably more comorbidity. So if we're seeing that benefit, it's probably going to extend to the elderly, but I just don't know.
Corey, thanks very much.